For hepatitis B, we have learned about the serology, virology, treatment approach. Here we will not talk about the treatment approach. Here we will be talk about the approach to a patient who was incidentally detected to be HBsAg positive. What workup to do, how to decide, all those things. Common scenario. A 45-year male who takes alcohol off and on. BMI is 29, so risk for fatty liver disease, alcohol, so alcoholic liver disease, diabetes, well controlled, all the possible risk factors presents. Without any significant past history, admitted with pain abdomen, planned for cholecystectomy because found to have gallbladder stone. Admitted, random blood sugar was found to be normal. Sorry, ये मेरी mistake है, slide गड़बड़ है. Blood pressure normal and bilirubin is normal. LFT is routinely done for all the patient before surgery, so LFT is showing SGOTPT is elevated. Now surgeon will test for HBsAg, SCV, HIV. Either you may get HBsAg positive or SCV positive or both positive. Scenario will remain the same, whatever be the positive. So how to move ahead? Shall we go ahead for the surgery next day or we should hold it? What workup to do? These are the questions we are going to answer in this session. So these are the 4 questions which you have to answer before taking up for the surgery. Whether patient is having acute hepatitis or chronic hepatitis. If chronic hepatitis, then it is cirrhosis or no cirrhosis. If cirrhosis, then compensated cirrhosis or decompensated cirrhosis. And these are the physician's question actually. Yeah? And then antiviral is to be given or not. That answer we have already given based on the criteria of treatment diagnostic criteria. So we'll answer each of the questions. Why we need to differentiate acute hepatitis? Because he might be having just incidental finding of HBsAg positive. He may have acute illness of some other type. Acute dengue he may have. He may have acute malaria actually. So we have to exclude all other possibilities for deranged LFT, especially in tropical countries, as well as acute hepatitis B. Because during surgery, if patient is suffering with any acute illness, surgery should not be done. Liver injury will be aggravated, risk of death, hospitalization, ICU stay, everything will increase. And ultimately, the surgeon will be the culprit. So we should be cautious. All these factors will help you to decide whether patient is having acute hepatitis B or chronic hepatitis B. But I have left one investigation here. Which one is that? Which will help you to know whether he is having acute hepatitis B or not. Batao, batao. IgM anti-HBC. If you are suspecting, then you can do IgM anti-HBC also. Otherwise, the viral presence of viral prodrome, seasonal variation about dengue, hepatitis A and E, marked elevation of ALT, sudden onset of jaundice. These features will help you to decide whether patient is having acute hepatic illness of any nature, whether it is B, C, A, E, dengue, malaria, typhoid, kala ajar, whatever, or it is a chronic illness. So best simple tool is to just postpone the surgery by 24 hours and repeat an LFT. If LFT is showing a marked change in 24 hours, whether up or down, that means this is an acute illness. पहले 112 120 था, वो बढ़ के 200 हो गया, 250 हो गया, इसका मतलब कि कोई acute illness है. और अगर उसी के आसपास है more or less 24 घंटे में, more likely patient is likely to have a chronic illness. So that is a simple test. That just defer the surgery by 24 hours and review it. Then the question is chronic hepatitis patient, whether he is progressed to cirrhosis or not. Why we want to know whether presence of cirrhosis is not or not? Because in post-operative period, there is risk of decompensation. There is a requirement for the prolonged hospitalization, ICU stay, expenditure may increase, risk of death is there, or you have to avoid some drugs because to avoid hepatotoxicity. So you should know beforehand that patient is having cirrhosis or not. So how you will do? Which test? Simple APRI test, AST platelet ratio index, ultrasound, and if you have FibroScan, you can do FibroScan. Otherwise, APRI ultrasound is good enough to give you a reasonable confidence that patient is having cirrhosis or not. When you are talking about ultrasound, please note that these are the features of cirrhosis on ultrasound: shrunken, small size liver, nodular surface, portal vein more than 12 millimeter, spleen more than 12 centimeter or 11 centimeter, presence of collateral. But unfortunately, most of the time we are getting on ultrasound is written is the last one, coarse ecotexture. Coarse ecotexture is not an indicator of liver cirrhosis. So we have to train our radiologists. Please mention your findings under these headings. What is the size of spleen? Collateral is present or not? What is the size of portal vein diameter? What is the size of liver? How is the margin? How is the surface? That will give you a clear-cut impression whether the patient is cirrhotic or not. Third is whether cirrhosis is compensated or not. This is already we have learned. Same feature. Why we want to know it is a decompensated cirrhosis or not? Because in these patients, risk of death is much more than in compensated cirrhosis. Whether the person is died due to decompensated cirrhosis or not, ultimately surgeon will be the culprit. So we should be very much clearly knowing beforehand how much is the risk of death. And definitely these patients will need ICU care, prolonged hospitalization, and lots of expenditure. So that's why we should know. And the way is just ask this history, ascites, HE, bleed, and if everything is absent, history of pedal edema, significant pedal edema. Does the patient need antiviral? That already we have learned based on the treatment guideline. Apply the same guideline here in your given patient after evaluation. If you find chronic hepatitis B, evaluate for cirrhosis, DNA, ENTN, and decide whether treatment is needed or not. It has nothing to do with the surgery itself. Then the question is the surgeon's concern. That was the physician concern who has taken a consultation from physician. Now, what surgeon want to know? Is it safe for the patient to operate upon? What is the risk of the post-operation complication and mortality? And what is the risk of HBV transmission from the patient? So definitely there is risk of transmission. I will not discuss much about it. Risk of transmission from the patient to the physician, but as per the rule, no one can deny a surgery or patient care based on this basis. It is the responsibility of the healthcare worker and the institution to take universal precaution and do all the necessary medical services. So we will concentrate only on risk of death. Why these patients of cirrhosis are at risk of increased death? Because of their nutrition is poor. So the post-operative period, their tolerance for sepsis, for fasting, for other things are poor. They have low albumin level and risk of hepatorenal syndrome, hepatopulmonary syndrome. These things are there, right? This is the just general overview that how much is the risk of death in an elective surgery and in emergency surgery in patient with child A cirrhosis, B cirrhosis, and C cirrhosis. Decompensated cirrhosis means late B or C cirrhosis. So you can see the risk of death is 70 to 80%. This is just a rough estimate. So in summary, child A patient tolerates surgery well. Child B can tolerate, C will not tolerate any major surgery. But many other factors are important, like which type of surgery it is. It is abdominal surgery or extra abdominal surgery. It is emergency surgery or elective surgery. All those factors are also important because earlier child was used. Now MELD is considered to be a better criteria to determine the outcome. So this is how you can get a rough estimate of death with the increasing number of MELD. If MELD is between 5 to 20, increase is mortality is by 1% for each increase in point. So if MELD score is 7, suppose a person is undergoing cholecystectomy and say general risk of death is 5%, say it is too high, I know, but it is 5%. So you have to add beyond 5 is 7, 2.2 and 5 baseline. 7 point will be the 7% will be the risk of death. If mild is say 20, from 5 to 20 is the 15 point. So 15% due to mild and 5% baseline due to cholecystectomy. So 20% is the risk of death. That is how you can do some rough calculation for OPD visit to express the risk of death and discuss with the family. That is the simple mathematics you can apply. Or you can use this webline website calculator and simply put on the values they will ask. It will give you the estimated risk of death, Mayo Clinics. So it's easy. This already we have discussed in summary. So if incidentally find HBsAg/C, we have to postpone the surgery for 24 hour, 48 hour, repeat LFT to exclude any acute illness. In chronic hepatitis B or C patient, exclude the presence of cirrhosis, differentiate between compensated and decompensated cirrhosis, explain the risk of death to the family, depending upon the type of surgery and the child status or mild status of the patient, and then take it forward. And in pre-op period, you can say low albumin, high bilirubin, low platelets. These are the indicators are likely to be poor outcome.